We're just going to wait and see if Uli can dial in now or.
Yeah, yes, that would be great. I'll see.
Okay, I will put this here.
Hey, he's here. Hey, Uli.
Uli.
Hi, how are you?
Very good. Yeah.
Good to see you.
Excellent. Welcome, Uli. Excellent. Hello, Nir.
Hi, good morning.
George.
Okay.
Hey, good morning, Uli. Morning, David. Morning, everybody. Morning or good afternoon. I'm sorry.
Nir, do you want to be the first one to go?
Yeah, no problem.
Good.
Can you hear me well, by the way?
Yes, yes.
Yes, doctor.
Yeah.
Okay.
So we'll just give a couple of more minutes and then we shall.
And then I'll share my screen, okay?
Yes. Thanks. How are you, Prof. Shlomi? You okay?
Very good. Very good. It's Sunday, you know. Our Sunday is your Monday.
Oh, really? Is it? I didn't realize that.
It's as bad as Monday. It's your Monday.
Excellent. So, I think I'll just get the good. I think we'll start with the introductions. So, good afternoon. Welcome everyone to this third Pediatric Neurosurgery Journal Club. This is an attempt to have some scientific discussions as well as involve young neurosurgeons to present at webinars, as well as to get input from senior colleagues to the discussions and to the science and how we proceed further. So we have got an excellent program today. It's on hydrocephalus, particularly every part of hydrocephalus is controversial, but certainly the neonatal ones following intraventricular hemorrhage and premature still is a matter of controversy. And so we have got two papers on that. And then we have got Professor Dia Pujari going to give a talk to us on how to manage hydrocephalus related to TB. So we will first of all start with Dr. Neeraj Shimoni. If I can ask Dr. George Jallo, and we have got three distinguished neurosurgeons as our expert panelists. We have got Dr. George Jallo from St. Petersburg, from Johns Hopkins All Children's Hospital. We have got Professor Shlomi Constantini from Tel Aviv, and we have got Mr. Richard Edwards from Bristol. Mr. George Jallo, I'm sure you all know him from all his books and publications. Same with all three. Professor Shlomi Constantini is very active in the ISPN, in the chair of the membership society, and also in the ISPN, and also the president of the IFNE, the Neuroendoscopy Society. Mr. Edwards is the clinical lead at Bristol, as well as the former chairman of the British Paediatric Neurosurgery group, and also the training program in Bristol. So welcome to all these senior faculty. So Dr. George Jallo, would you be kind enough to introduce Dr. Neeraj Shimoni, please? Thank you.
Yeah, yes. Good afternoon, everybody, and thank you, Naren. I think this is a great morning or afternoon to be able to spend with distinguished colleagues speaking about these papers. The first paper by Neeraj Shimoni and really written by Uli Kamali will lay the groundwork on a study what I'd like to say about Nir is that I had Nir finished his residency with Shlomi in Tel Aviv. So thank you, Shlomi, for allowing Nir to come to the United States to do a pediatric neurosurgery fellowship with me in St. Petersburg, Florida. And I think Nir was a star from the very beginning. It really is a testament to the training that he received under Shlomi. And within his year and a half of pediatric neurosurgery fellowship, you realize that he was destined for great things. And Nir left us to go to become the chief of pediatric neurosurgery in the Geisinger Health System in Pennsylvania. And as the chief of pediatric neurosurgery, he really is doing pediatric neurosurgery as well as all the epilepsy surgery, both in children and adults, for probably the most of the western state of Pennsylvania here in the United States. And with that, I think, I can't, his mind as an analyzer of many papers as well as an author is exceptional. So Nir, I will let you present the paper by Uli, who also is a good friend of mine. And before we start, I do want to wish Uli a happy birthday. I think, Uli, you're turning 50 in a few days on December 12th. So if we could all wish him a happy 50th birthday in this pandemic on Zoom.
Happy birthday, Uli.
Happy birthday, Uli. He still looks young as ever, so
Yeah.
Great. Thank you very much, George. Dr. Nirshimoni, can I ask you to please share your presentation and give us your thoughts on the paper by Uli? Thank you.
Yes, thank you very much. First, thank you very much, Naren, for this opportunity. I'm lucky because two of my mentors are here. I started with Professor Constantini, and I saw that Dr. Roth here as well. And of course, Professor Jallo, that I've been spending with him the last few years, been a great mentor and still is. And Professor Tomale, Mazel Tov, happy birthday. So we'll start with the presentation. Let me see that I'm doing it correctly with the screen. Can you see it?
Yep. Yes, we can see it.
So
if you put it on presentation mode for us,
yep.
That'll be brilliant. Excellent.
Is that okay?
Yeah.
Okay.
Excellent.
So we're going to discuss today a very nice paper by the group of Tomale from Charité in Berlin regarding the neurodevelopmental outcome at 2 years of age after lavage, endoscopic lavage in neonates that had a post-hemorrhagic hydrocephalus. This work is a part of a greater discussion, like you said, Naren, and I'm going to address that before we'll dive into the article itself. So a very quick refresher about IVH. I'm sure that everyone on this audience are quite aware of all the details. I'll give some words about trophy as well as the drift study that are being discussed in this article. And some about the tools that have been used for the neurodevelopmental assessment of the neonatal group. So let us begin. So IVH, I don't need to go further deep with words about that for this group. It's about 25 to 30% of the premature infants will develop that. And not all of them will develop a hydrocephalus eventually. It usually comes in the first 3 days of life for the patient. And affects coming from the germinal matrix, ventricular system, as well as the parenchyma with grades 1 to 4 that all of you quite aware. Now, the outcome of the IVH can be quite horrendous to the young brain, going from the development of hydrocephalus with shearing force on the white matter, as well as the cytotoxic effect on the brain parenchyma, most likely from the blood products that affect the brain, eventually can cause CP, can cause a motor and cognitive decline of the patient with a significant outcome measures when the kid is becoming older. And the shunt dependency in different articles goes between 40% to 90%, usually around 60 to 70% for this patient that developed the IVH. The treatment, as you all aware, is usually the definite treatment of either a shunt. Later in last few years, there is discussion about the ETV or the ETV CPC as well, but still the shunt is the real workhorse or the for treating the IVH or the hydrocephalus that comes after it. But as we all know, for this age group with the low birth weight, the use of shunt right ahead is usually not possible because of the high chance for a complication or even infection. And hence we use temporizing measures, can be a ventric, can be a serial taps, ventricular access device, subgaleal shunts, or even the medicinal options to reduce CSF production. At the end of the day, most centers use either a combination or the use of subgaleal shunt, ventricular access, or AVDs. And none of these really showed any superiority over the others. There are some discussion about which one of them gives a higher chance for arrested hydrocephalus. But in the end of the day, there is still debate. And part of it is what the trophy is trying to give us as an answer eventually. So we talked about options to remove and treat the hydrocephalus, but what about the other culprit, which is the cytotoxic environment for the brain? And hence came from Bristol, UK, the study in 2003 about removing the blood products from the ventricular system using the drift study, the drainage, irrigation, and fibrinolytic therapy. The first publication as a single center was in 2003, then a multi-center in 2007, and then 2 follow-ups. One of them is fairly recently regarding a long-term follow-up. The first results were quite promising. Later on the multi-center trial, it didn't show the same results with basically no difference between the groups, the control and the drift group regarding the shunt dependency or mortality. And what was more worrisome was the fact that about 35%, almost 5-fold chances to have a secondary IVH for those that got treated. Yet they continued their follow-up and showed that in 2 years after the inclusion of the study, there was a significant reduction in the severe cognitive disability by the Bailey score, which means less than 55 when you compare that to control. And that was quite nice to find it was sustainable when those kids become in the age school in the 10-year follow-up that was just recently published. So with this come into hand, it showed that the removal of those cytotoxic agent or the blood from the ventricular system has benefit from a cognitive outcome. The Lavage came into this discussion as part of the trophy that we're going to discuss, but it's a standalone procedure, and this article is not part of trophy as far as I know, but maybe Professor Tumala can elaborate about it later on. The Lavage was already discussed in the past from 2004 and later on as a tool to remove blood product from the ventricular system in IVH without the use of fibrinolytic agent. Of course, it means that you do the procedure in the OR. It's a more secure environment and more controlled environment. And it was shown to have a nice result in terms of reduction of shunt frequency, infections, and the chances to develop a multiloculated hydrocephalus. So into that came to be the trophy. And the trophy is basically a new registry from 2019 that take 4 modalities, the lavage, the use of EVD, the ventrix, the ventricular access device, and the subgaleal shunt, and basically try to see, give us data about safety, efficacy, and long-term neurodevelopmental outcome for this age group with long-term follow-up after 5 years of age. This is a comparative prospective multi-center studies with many of the centers that are involved are part of this discussion this morning or afternoon. And I'm waiting to see the result that will come out of this registry. That's quite interesting. So for this article, they use 2 different methodologies for assessment of the neurodevelopmental status of the patient. The first one is quite known and been here around for years is the Bailey score. The article that the group of Professor Tumala used was the 2nd edition. Today we already have the 4th edition in hand, basically trying to give us a picture, and that's important to understand. A Bailey is a snapshot picture of the status of the patient right now in regards to memory, learning ability, problem solving, etc., in a playful environment. And we need to understand we're still talking about a neonate, a baby that needs to be assessed. And the scores go from 85 and up. That means that that's a fairly normal development status of the patient. 70 to 84, there is some mild developmental delay. Less than 70, that's quite more significant. And less than 55, that's a severe cognitive disability. And this is the subgroup that the drift study showed that it had a benefit in the long-term follow-up. Now, the Bailey score was shown in the past already not to be a great tool to assess motor development. So nicely enough, this group that published this article used also the use of the gross motor function classification score, basically the GM-FCS score, in order to assess the motor outcome of their patients. This is a score that we know from spasticity, whoever is dealing with spastic children, as order to have their status assessed. And it goes from 0 to 5 or 1 to 5, with basically the first three, the 1 to 3, give us a patient that is able to walk to some degree, either freely or with assistant. With the 1 and 2 score give us a patient that can walk with relatively mild assistant or without any assistant. 3 already needs some handheld mobility device. 4 and 5, this is a severe motor decline or deterioration, which means that is not able to really walk without any significant powered mobility device, or is not having any kind of independent movement. And I'm going to repeat that quite a bit during the presentation. A higher score in the GM-FCS, it means that's a good status. That means a bad status of the motor function, where a lower score, it's a good status. So hence the authors describe the worst outcome as a Bailey that is less than 70 or a GM-FCS that is more than 2. So their goals was not to show that the lavage is a feasible technique that was shown already in the past. It was to show what about the neurodevelopmental and motor outcome at 2 years of age, trying to compare that to what the drift just showed. And also, they also assessed the relationship of the brain and ventricular volumes in terms of the outcome at 2 years of age, and went to exploratory search also for risk factors for the same outcome. So their methodology was a retrospective analysis of their stored data. They looked at 2010 to 2016 and found 45 patients that were operated for the Neuroendoscopic Lavage in Charité in Berlin. And their inclusion criteria was quite simple. The patient needs to be alive at the age of 2 years of age in order to have the assessment. Hence, one patient was excluded because he didn't survive. Their protocol was, or their practice, because that is a retrospective study, was to have a Bailey assessment and the GM-FCS assessment at 2 years of age, as well as high definition MRI that will allow them to do volumetric analysis. Like we know with retrospective studies, not all the time you get all the data that you want. That's what happened here as well. They had only 2 patients that were lost to follow-up, which is quite nice. So at the end of the day, 42 patients got into the cohort as a patient with some degree of data. Not all of them had all the data points. 36 had the motor assessment, the GM-FCS, 27 had the Bailey score, and 29 had high definition MRI that allowed analysis. Yet when you look at the graph on the right, you see that from those that had the Bailey score at 2 years of age, 30% of them had a fairly normal neurocognitive status, which is quite significant. From the motor perspective, almost 80% of them had either free ability to walk or needed just very mild assistance. So those results are quite remarkable. For the patient that didn't have all the results or all the tests, for those that didn't have the Bailey score, the trend was that they had a lower GM-FCS score, which is better, a lower body weight at the lavage time, and a lower proportion of IVH grade 4 and shunt dependency. For those that didn't have the GM-FCS score, they had a lower body weight at the lavage time, and they had a higher proportion of IVH grade 4 and higher proportion of comorbidities. The last two are important because those are potential risk factors to have a worse outcome that might affect the nice result of the 78%, 80% we just showed regarding the good outcome of the GM-FCS score. In terms of the analysis of the volumetric parameters of this study, they found that there is a correlation between high Bailey score, which is a good thing, with higher brain volume and lower ventricular volume. They saw that for the GM-FCS score, there is a lower GM-FCS score, which is a good thing, with higher brain volume and with a lower ventricular volume. They found that the correlation of the brain volume was stronger than the actual ventricular volume and more significant for the GM-FCS score. So you see the trend on the graph. And again, to correlate the GM-FCS score, we want it to be with lower numbers. In terms of the exploratory risk factor, they were sent to found. Their outcome measure was the worst outcome, which means Bailey that is less than 70 and GM-FCS that is more than 2. And they found that gestational age, time from hemorrhage to the lavage, or the fact that the patient had or didn't have a shunt had no association with the worst outcome. The IVH grade 3 and 4 versus 2 might have some significance, but it's important to remember, and they mentioned that they had only 4 patients with grade 2. So the comparison is problematic. The use of anti-epileptic drug as a way to think about seizures or epilepsy even, or the presence of comorbidities or any posterior fossa pathology like cerebellar atrophy or isolated forced ventricle, basically had potential importance as a risk factor for worse outcome. When they went into a univariate analysis, basically those parameters got a stronger significant as the old ratio, almost the 5-folds. When they look at the shunt dependency, at their study, 60% eventually became shunt dependent. And when they look at the timing of the lavage, how aggressive they need to be, how much fast it needs to be pushed, they didn't find correlation between the timing of the lavage to any shunt dependency as an outcome. Even when they adjust the gestational age, the IVH grade, comorbidities, or the presence of infection, at the end of the day, the lavage timing had no effect. On the other end, higher IVH grade or the presence of infection might have indeed importance in terms of having a shunt eventually. So far, what they showed is that the results in terms of the neurodevelopmental outcome from the Bailey score, as well as the motor outcome, was quite nice and significant. Were quite nice and significant. In terms of the risk factor we just showed, there are some risk factors that are potentially important to have worse outcome, while others that are interesting, like the time for lavage, had none. Now, when you compare that to result of the drift, because we started from there, we started from the fact that the drift showed that in long-term follow-up for the subgroup of the severe neurodevelopmental outcome, less than 55, they had a reduction. They compared the result to the drift. And they found first that their baseline parameters was less or more the same and comparable. And then they look at several outcome measures. They drifted a much more secondary IVH. In mortality, in this specific article, they had 2%, they drifted about 6%. But they do mention the fact that when you compare that to other articles about the lavage, it's usually around 5%, so less or more comparable. Infection rates was higher in the lavage, in the drift, basically almost none. When you compare the actual parameter that we wanted to discuss, which is the Bailey or the neurodevelopmental score, this article of the Lavage had a higher proportional outcome or good outcome for 85 and up for the Bailey score, whereas the drift at about 23%. And this trend is less or more sustainable until we look at the very bad subgroup of less than 55, when the drift did much better with 31% versus 44. Altogether, the authors conclude, and I think that's quite reasonable, that the results of the Bailey are at least comparable, if not better, for this Lavage so far, although the cohort is quite small. Now, in terms of the motor assessment, that was more problematic. And they were not nice enough to describe that the drift study didn't use the GM-FCS score as their way to describe motor assessment, whereas this article did use this score. So it's hard to compare. So they try to depict the specific parameters from the description and try to compare. And what they found eventually is that a normal walk or ability to walk was about 17% in the drift study, which was lower than what we saw in their study of the Lavage. 44% of the patient in the drift group were unable to walk or had significant disability in terms of ambulation. That goes with correlation about GM FCS of 3 and 4, which is about 22% in the Lavage group, in the Lavage study story. So altogether, it seems to be that the Lavage did better in terms of motor outcome, as much as we can compare the two studies. And this is at 2 years of age. Now, in comparison of the shunt dependency, the drift did much better with about only 40% versus the 60% in the Lavage group. But it is important to mention, and I agree with their statement at the discussion, that it's hard to compare this specific parameter because there is no real consensus about when to treat the ventriculomegaly or hydrocephalus in this age group. Some centers try to push it as much as they can until the patient really develop signs of elevated ICP, and some try to be proactive and reduce the ventriculomegaly in order to preserve parenchyma. This is an ongoing discussion and debate regarding which is better and when do we need to actually act. So in summary, we can say that this article showed nicely that about 1/3 of their patients that had the Lavage had a fairly normal or close to normal neurodevelopmental outcome from the Bailey score. And almost 3/4 or almost 80% of their patients had a fairly good motor outcome in terms of either free walk or with minor assistant. Almost 2/3 or even a little bit more did not suffer from epilepsy or a real seizure comorbidity. And this is from the benefits of the patient. Yet, they had 44% of their infant that had severe cognitive disability. Their portion underneath the 55 in the Bailey score was higher than the drift. And about 20% of the patient eventually didn't walk or needed a significant mobility device in order to be ambulate. In the logistic regression analysis they did, they found the combination of anti-epileptic drugs, presence of comorbidities, or cerebellar pathology to have association with worse outcome at 2 years of age. And the nice or interesting fact is the fact that recent articles, when you look at the volumetric analysis that started to be quite out there, I would say in the last 10 years, is that a lot of us look at the ventricular volume. They looked at the brain volume and saw that the brain volume parameter was more important or more significant when you compare that to the Bailey and the GM-FCS score in terms of the outcome. That's quite interesting in my mind. The conclusion or the take-home message from this article is that the Lavage showed at least similar, if not a little bit better outcomes in terms of neurodevelopmental and motor outcome when you compare that to other technique or the drift study, it's important to continue and do studies with as much as possible comparable tools, so we'll be able to compare the different results. I'm waiting to see what the trophy will show us. The cohort, and they say that is too small, 42 patients, and eventually not all of them had all the studies, so it's hard to compare and depict everything from this study. And the idea of volumetric analysis, that's interesting. That's something that needs to be assessed and discussed in future works. The incomplete data we discuss, and the other thing that needs to be taken into discussion, especially with the comparison to the drift, that they did a very good job trying to depict the details and compare, for example, in the motor comparison, but at the end of the day, those studies were not meant to be compared. So it's not a clear-cut comparison, although we can understand and have some conclusion out of it. Thank you very much, Professor Tamala. I enjoyed your article. Thank you.
Thank you. That was amazing.
Thank you very much, Dr. Nish Moni. That was a very clear and very well analyzed critique of the paper, bringing the positive and the limitations. And once again, congratulations to Uli. Please put your questions for Dr. Shimoni and Prof. Ali on the chat box. I'll bring you to the microphone. In the meantime, I'll get the opinions of our distinguished panel here. Mr. Richard Edwards, in Bristol, you and your colleagues did the drift study. What's your first of all your thoughts on Dr. Shimoni's presentation and your take on the paper from Charité? Thank you.
The first thing, a great presentation there, fantastic, a very nice summary. And Uli, thoroughly commended on trying to push the boundaries forward some more in this difficult area. And I know you've worked hard for a number of years on this. It's really great. I think, fundamentally this comes down to, and from a neurosurgeon's perspective, you've got one procedure that is the endoscopy that's appealing to neurosurgeons. We like endoscopy, we like washing things out, we like an instant result. And it's easy when the baby gets back to the NICU, there's no worry about the NICU nurses screwing up the lavage or anything post-operatively going wrong. And so on that sense, there's an appeal. Against it, and in favour more of drift, perhaps, is that drift is less invasive. The drift catheters are far smaller than an endoscope when it comes to putting in. And when you think of the size of a neonate's head, an endoscope is quite a big thing. Proportionally, somewhat more like a broomstick going through our forehead rather than a catheter, and so proportionally the endoscope is a lot bigger, and I've got a few anxieties about that, and Uli may want to comment perhaps on delayed imaging, what that looks like further down the line. I think both techniques, the endoscopy seems to provide a sort of almost an accelerated drift, and you're washing out and getting rid of the cytokine load over a very short period of time. My experience with endoscopy in very prem babies, and I don't know whether Uli or Shlomi will want to comment on this, is that they don't like it very much, certainly ventricular irrigation and endoscopy, and I think seizures have a higher frequency in very tiny babies after endoscopic procedures, and I do wonder whether the drift is a sort of a slightly, in some ways, gentler approach than an endoscopic procedure. A couple of questions for Uli. Firstly, I think that the devil is in the detail with a lot of these, and I think one of the difficulties in comparing drift with the lavage is that because by its nature it's the retrospective study and they're not randomized comparison, there are differences between the groups. So I think in Uli's group, Uli, you had about a 10% grade 2 IVH rate, and I think drift was all grade 3 and 4 IVHs, and that's going to have some impact on the outcomes. And the other thing is, and again, the looking through the table, in table 2, the birth weights are slightly higher in the Lavage study, but on table 2, the lowest birth weight was 809. I think in table 4 it's 520. I don't know if is there a difference in the groups, but is there, I mixed up the interpretation of the birth weights, but it looks as though the birth weight on average is a little higher in the Lavage group, and again that may give them ever such a slight advantage if they're slightly later in terms of risks and potentially outcomes. But the big thing for me was this discrepancy in the shunt rate. So either we undershunt our babies in Bristol or Berlin have perhaps a slight tendency to overshunt, because the neurocognitive outcomes, which are also dependent on the sort of, I guess, the quality of getting rid of the IVH, are comparable. So quite a lot of thoughts. There's a real food for thought, Uli. I think it's an impressive study, and I've definitely got buy-in. I want a randomised trial though, not the trophy registry. Rift versus Lavage.
Thank you very much, Mr. Edwards. That was a very thoughtful comments and questions. Uli, Professor Tamale, could I please ask you to?
Yeah, thank you very much. Thank you, first of all, Nir, for giving this very nice overview and also some critical aspects with our detailed background information you put very nice together. Thank you very much, Richard, because you pointed out the important facts, and you're absolutely right that it's very hard to compare a single center study with a multi-center study which has been done prospectively and randomized in the whole setup. So you're absolutely right, and you're also right and that's why we put up the table 4 actually to compare the neuroendoscopic lavage cohort with the drift cohort to pick out especially the differences between both, in order to critically analyze our data compared to the other. However, I think it's very important to understand that the drift and the neuroendoscopic lavage is there's a continuum between both. And it was interesting that you said that it's less invasive to put external ventricular drainages than to put an endoscope, which is right if you look only from the surgical perspective. On the other side, you have one intervention, you don't have different shifts of nurses and medical staff going over the whole setup which is needed for drift. You have 2 entry points, so the whole setup is quite different between drift and neuroendoscopic lavage. But since I think it's in a controlled environment of the operation room, I would rather say it's less invasive and a little less harmful than I would imagine drift. However, I've never done drift, so I don't know. I see the continuum between both, and I see the neuroendoscopic lavage as a further development of drift. And without drift, neuroendoscopic lavage would never be possible. And that's why we pointed out those, we like to compare our data with the drift study. And that's why we try to make it as objective as possible.
Tamal, in terms of the size of the endoscope, did you use any very small endoscope, or did you use the standard size endoscope?
I have to point out that you have to use a standard size endoscope, because otherwise you don't be able to get the clots out. The clots are very soft, and it's very different to neonates compared to older children, where the clots are very firm. But in neonates, the clots are very soft, but however, you still need a bigger size endoscope, and we use the Minop endoscope, which has a outer diameter of 6 millimeters. This outer diameter enables the inflow and the outflow channel being big enough in order to have enough volume exchange, as well the outflow diameter being able to aspirate the clots.
Have you tried a flexible scope, Uli? I've used a flexible scope for the endoscopic lavages we've done, which is a bit smaller, but you can get the clots up. I agree with you that it does depend a lot on when you go in as to how difficult the clots are to get out. And I know Christian Aquilina is very much of the view of sort of wash out all the liquid blood until you get it clear and accept that you're going to leave some clots in there. I don't know what your view is. Do you try and get every clot out, or do you accept that some won't come up the scope?
We try to get all clots out which are accessible. And so, for example, the temporal horns clots are not accessible necessarily. Otherwise, you can maybe wash them out to get them freely running into CSF and then aspirate them. But if they're sticky to the choroid plexus, you just leave them in. So we just take what we get, but what we get, we try to get everything out. And this is actually most of it.
And do you find the babies are jittery or having seizures immediately afterwards? I see that you had a low seizure rate in the long term, but certainly ours seem to have early seizures when I've scoped very tiny babies. Have you noticed that? Or?
Yeah, that's a very important question, and I have got this quite often. What we do is that we normally leave the babies intubated for 1 or 2 days on the NICU before get them extubated. That's why we maybe don't see that. Because I got this question, we put in our 2018 article in World Neurosurgery the rate of anti-epileptic drugs on the NICU, and we had more anti-epileptic drugs given to the babies before the surgery compared to at discharge. However, we see some, if we have waken up them earlier, we see some shivering of the extremities, which lasted 1 or 2 days, but then it's over. And all babies have been better after surgery compared to before surgery.
Thank you very much. I'm just moving on to Professor Shlomi. Professor Shlomi, on your former protege's presentation, as well as questions for Uli and your thoughts on his work. Thank you.
Naren, would you like me to comment now?
Please, thanks. Yeah.
So Nia, this was an excellent presentation, very detailed, and Uli, you know, it's interesting. I've heard you give this talk several times, and each time I learn more things that uncover. And perhaps you also learned from Nia about your own study when you read it again. So congratulations to both of you. I want to light a little different perspective, which is the following. This is a very invasive procedure, okay? Everybody would agree. You take a little baby, you put a scope in, it's a significant scope. If you put it with a peel away, without a peel away, you do a big hole in the cortex, you wash it out, there are temperature issues, and it is very dependent on the surgeon and on the system that takes care of these little frogs that we take to the procedure. So I'm a little afraid that once you spread such an invasive procedure that is dependent on one master surgeon that accumulated experience, you're going to get an increase in the complication rate. For myself, the risks are even more important than the benefits. I'm a little skeptical whether on anything that is less than hundreds of premies on each arm, we can show a real benefit. Because a lot of the damage in IVH is caused by the bleeding itself. The hydrocephalus and clearing of the blood is probably just an additional component in the damage. So let's say the damage at 50 or 60% is created by the bleeding, and then you're playing on an additional 40%, and you have a 10% improvement. You need huge numbers if you, by any means of power analysis. So I am very interested in the issue of rate of complications. And you know, like many others, like Richard, like you said, I was disappointed, but I understood the decision not to do the trophy in an IIHS type of design because it would probably not happen. I want to mention that the numbers of post-hemorrhagic hydrocephalus in our center has been reduced dramatically over the last few years. So even Jonathan, who is here with me, listening, and who is really a master endoscopist, we were a little worried that we will not be able to get enough experience for this specific procedure because we do not have enough cases. So I'm concerned really that once we take that technique out of the single center with a master surgeon, we're going to have a steep increase in the complication rate, and then that little benefit, if it exists, will dissipate over time. So, Uli, what do you think?
Yeah, thanks, Shlomi. According to the complication rate, you are absolutely true that it's very important. Don't look only at the neurosurgical part, look also at the anesthesiology part, look at the neonatology part, which needs a lot of experience to transfer the small babies into the operation room and back to the NICU and stabilize the patient after surgery and all this stuff. This is one issue. The other issue is the complication rate. We detailedly reported on them in the 2018 paper. And this was not only our group, this was another group south of Berlin, Leipzig, who included 11 patients, and we included 45 patients. And in those, we had a mortality rate of 5.4%, which is still better than what you see in the literature. However, one of the small babies were actually dying right after one of the intervention in the other center during their learning curve. So you are right that there is a risk, and this is an invasive procedure, and it needs a lot of experience, not only from the neurosurgeon being a good neuroendoscopist, but also from the whole team to manage those babies. However, looking at all those complications we have reported, the technique has been to show safe, and it is feasible, and it made our life much easier than before. We do this technique routinely since more than 10 years now at the Charité. So we are looking at a long-lasting experience on this technique, and it's not a new technique anymore in our center. And our neonatologists would have forbidden us to do this if it would be too risky. So I think this is one important thing to mention.
Thank you very much. Thanks, Professor Shlomi. Thanks, Uli. Can I go to Dr. Jallo? Dr. Jallo, both on Dr. Shimoni's presentation and Uli's important work. Thank you.
I mean, Uli, first I do congratulate you on the paper. I think you are pushing the field in the management of IVH in these children. I think Nir did a great presentation, but again, I think I'm going to lean towards Richard and Shlomi. We looked at this at our center with the trophy study, and the reservations I have is similar to the others. I think it has to be done at an experienced center. I think if we do open it up to multi-centers, I think we're going to see the complications increase dramatically, which will then wash out, as Shlomi said, the true benefits of performing this. I can say, I think, as Uli has mentioned, it's a team. It's not just the skilled neurosurgeon doing this. It really takes the anesthesiologist, the transport of that baby from the neonatal intensive care unit to the operating room and back. And I think it's critical, Uli, that you do mention that you maintain these babies intubated for several days. I think that needs to be highlighted in anyone that is considering performing this procedure or surgery at their center. And then finally, I think, you really need buy-in from the neonatologists. I can tell you, we just did a subgaleal reservoir in one of our babies 2 weeks ago, and that child developed a subdural because when transported back during the transport, he had some overdrainage into the subgaleal space that resulted in a subdural. Fortunately, that child's doing well, but I can only imagine what would happen with the the more invasive procedures. So I do commend Uli for the paper and Nir for the review, as well as all the discussants on this. Thank you.
Thank you, George. Dr. Professor Tomar, do you want to come back? Thanks.
Yeah, thanks, George. You're right. I mean, as we said, it needs definitely experienced hand for neuroendoscopy. Even if you know how to do neuroendoscopic lavage, and if you know it, it becomes not a highly sophisticated intervention, but in those small babies, it is. And you have to do it very safe, and you have to know what to do, how to navigate in the ventricles, which are normally not as big as others. However, it's feasible, and I think a lot of training is necessary. And I don't know if really putting two EVDs and washing the ventricles out with additional medication is a safer technique. So we need to do something about those babies which are severely ill. And this is one approach which has shown to be feasible in our hands. And I think training and more experience is necessary to judge about it in the future. The other thing I want to mention is that trophy is not about neuroendoscopic lavage. Trophy is about comparing neuroendoscopic lavage to established techniques. So everybody who's doing other techniques are very welcome to take part in the trophy study in order to show either that neuroendoscopic lavage is good or bad. And I'm open to see what the future will say.
There's a good question from the audience. Uli, do you use suction to aspirate clots, or do you just lavage? What's the time interval between detection of IVH and neuroendoscopic lavage?
Yeah, we actually do suction. We do intermittent suction with a 10 ml syringe to the outflow channel if the endoscope goes close to the clot, and then it's easy to aspirate them. In terms of the time interval, the hydrocephalus needs to be there. And the hydrocephalus needs to be there showing dynamic parameters in terms of ventricular width, fontanelle being under pressure, and also the head circumference crossing the percentiles more than it should be.
Thank you very much. Professor Diapujari, have you done endoscopic lavage in your practice?
We have done it for infections. We have done hardly a couple of cases, and for hemorrhage, it has been mainly for infection, but it is something which we may probably start. Our main problem is to maintain these babies after the lavage. And that is one major reason why we are reluctant to take it up on a regular basis.
Thank you. We have got two distinguished neonatologists with us. One is Dr. Mohammed Eldib from Brigham and Women's Hospital. Dr. Eldib, what's your thoughts from the neonatal point of view on the work from Charité? Thank you.
Thank you. It's really a pleasure to be here today and enjoy this nice presentation. I think my point, which I think would be elaborated in the review article, that probably the big question is when to intervene and how much time are we leaving these babies exposed to this injurious blood component and let their ventricles get larger until we intervene. So I think, although I know that there's a lot of discussion about technique, I think the big question is probably if you wait too long and you intervene after progressive dilatation and after more injury happens, probably you end by not the outcome you are aiming for. So I think that like my only concern is if we are comparing the endoscopic surgery to the drift, but I think that still the percentage of abnormal outcome is quite significant. And I didn't hear much about the timing when this surgery was done. But I was not involved in the drift, so I don't know the impact of neonatal care, but it seems to be very significant and meticulous procedure, which probably an endoscopic intervention could be, the neonatologist side could be easier to manage.
Thank you, sir. Thank you very much. And we have got Professor Linda D. Veris, who was the lead investigator for the LV study. Professor D. Veris, I think you're from Utrecht. Would you be kind enough to share your thoughts on Dr. Professor Thomas' work and on drift? Thank you.
First of all, thank you for allowing me to listen to you. I really enjoyed this presentation and also the discussion afterwards. It's really, really interesting. I used to work in the Hammersmith Hospital, so I know Professor Whitelaw quite well, and was also a little bit involved when he started to do the drift. And this is a very interesting new approach, which doesn't go on for such a long time, so seems to be safer. I think it's really interesting, and another way forward. I'm a little bit anxious about the time that the procedure is being performed, because the ventricles are much larger than we tend to have them when we are inserting a reservoir in our patients. And I wonder, in the presentation, it was mentioned that the time till the procedure was done didn't have an effect on outcome. And I wonder whether the time was also related to the size of the ventricles at the time that the intervention was performed. So whether the size of the ventricles, the degree of ventricular dilatation being above the +4 millimeter line, was it very different from the children who did better than the ones who did worse? Or was it mainly dependent on having an associated periventricular hemorrhagic infarction in the brain parenchyma?
Thank you, Professor D. Veris. Professor Thomas, do you want to?
Yeah, thank you very much for your thoughtful comments. In terms of the timing of the lavage, again, what we see if we do an early lavage, we see a very nice ependema, which is not affected by any blood degradation products. And it seems to be appealing that an early lavage should be much better than a later lavage. However, we need a little bit of a bigger size of ventricles in order to safely navigate inside the ventricles. And so the safety issue plays an important role as well. We could not see statistically that timing plays a role in terms of outcome, as well as in terms of the necessity to put a shunt. However, in my tendency, I would say there is an important factor in timing. But we could not make it clear in our data, and I think it needs much more data to prove the factor of timing, or to evaluate better what is the factor of timing.
Well, actually, I think it would be really interesting to do a randomized trial and to either do the reservoir or do your lavage, your NEL, and see whether there are any differences. And
that's also very important and also true. And we discussed a lot about doing a randomized trial, which was difficult due to many reasons. And then we ended up doing this trophy study. I'm not saying that it's not possible, but it was difficult, at least from our German perspective at this time when we started the trophy. But you're completely right. If we would have a randomized trial, we would have less discussions maybe.
Well, discussions are always nice. Thank you.
Thank you very much, Professor D. Veris. Professor Thomas, that's an excellent paper, and congratulations on very thought-provoking, and also from what you have published, a very beneficial operation. I know just trying to do a small study is hard enough, but you have done excellent work. Just one question to follow up on what Mr. Richard Edwards said. In the post-op MRI scans, have you looked at the T2 weighted changes, or the changes from the endoscopy? Have you quantified that?
We did not quantify those changes directly, because we are not doing imaging right after the intervention, because we are totally okay doing ultrasounds after the intervention. The first MRI is normally done after 12 months, sometimes earlier. if we need to like look for the shunt, or if we want to take out the reservoir because it's not needed anymore. And that's why we looked at the defect where we put the endoscope in, and that was not significantly larger than what we would expect. And also we looked at the brain volume, which we thought is the most important factor in the future.
Thanks, thank you very much. And the other question is, I looked at the paper, and once again, impressive work. In terms of the statistics, because of the missing data, you had used imputations, data imputations, and quite complex statistics. How confident are you with the imputations of the data and the conclusions, Robert?
Yeah, we had a very tough statistician helping us with this paper, which was very important. And the imputation was done because there's missing data, and the missing data is actually described in detail in the supplemental material. And there you can see what kind of patients are actually missing for which kind of outcome parameter, in order to see are we looking at the better part of this cohort or at the worst part of the cohort. So all this is transparent. And that's why they are using this very elegant approach to include the missing data into the statistical analysis. But I'm not the expert. We took an expert who helped us with this.
Thank you very much. For the participants on the website that I have put on the link, if you follow it, then I have put the links to the multiple imputations, introduction to that. It's a very powerful, robust technique from what I read, and also Bayesian logistic regression. There's a tutorial how to go about it. And also Professor Tomal and team use this segmentation software, and that's very, I can see that me using this. And once again, I have put the link, and it's also on the link, or the link is on the paper as well. So I really thank Professor Tamale. I hope he has found it very rewarding. I think we have had so many discussions because the paper is so important, and thank you very much. And Dr. Nirshimoni for giving us a fantastic presentation on this paper. Thank you very much to both of you. Now we will move to, thank you. Thank you, Thomas. Now we move to the presentation by Dr. Daniel Kozyrev. Dr. Kozyrev, I have known him for now 2 or 3 years, and I know his work with Professor Hernes near me, and in digitizing his 1,000 videos. And I had invited him to London when I was in London for a course on information technology for doctors. And so may I ask Professor Shlomi Konstantini to introduce Dr. Daniel Kozyrev. Thank you, Prof.
Well, Daniel has been with us for, I think, almost 3 years. He's our fellow, a senior fellow from St. Petersburg, the real St. Petersburg, the original St. Petersburg. And we enjoy every minute that he's with us. He's really a combination that would certainly make him a leader in the field in the future. So actually, I just wanted to say before that I think it is extremely rare to have a discussion on such a topic with people like Professor Linda de Vries and my esteemed colleagues. So it's pure pleasure, scientific, intellectual pleasure to be part of it. Now, I enjoyed tremendously the initiative of the Journal Club before. I think it's a fantastic format from Naren, who really is the only one, I think, in the world that can keep the momentum of pushing on subjects in this specific format of a discussion, which happens more readily even than in physical meetings. So congratulations to Naren. And then when I read the paper from Dr. Eldib and the group, and Linda is there and some of our esteemed friends, I was relieved. I must tell you, because this, for the first time, gave a nice summary of a complex topic that followed my initial bias. I have a bias, I admit that. So Daniil, Naren, my bias, and the wonderful overview of the group of Dr. Eldibel, Nilda, and Abhaya, and some of our friends.
Thank you very much, Professor Shlomi Constantini. And Dr. Daniel Kozyrov, if you would please share your presentation and give your talk. Thank you.
Yeah, thank you, Naren. I'm going to share my screen now. Please tell me if you can see it. And
yeah, we can see it. Yeah. Thank you.
Yes. Thanks a lot for this opportunity. I want to talk about this paper that Dr. Eldibel and the constellations of authors published quite recently about the management of the ventricular dilatation, post-hemorrhagic ventricular dilatation in infant born preterm. So here you can see the title and the representative from different centers. It's like world leaders in this topic, and it's giving the quite good review of this quite complex topic. So first of all, in continuation of the Nir's talk, I want to say a few words about the background, especially for the young colleagues who is not a lot of aware about this difficult topic. So up to 50% of infants were born extremely premature. It means that before the 28 weeks, and the half of them will develop this post-hemorrhagic ventricular dilatation that you can see on the right part of the screen. So the reason of this hemorrhage is this germinal matrix that is quite complex object to understand. It's located in the caudothalamic groove that you can see on the left part of the screen, and it's filled with the very fragile vessels that be the origin of this the hemorrhage, intraventricular hemorrhage, and follow post-hemorrhagic ventricular dilatation. So here, presenting the theory, how it is developing. So the blood coming from these fragile vessels going to the ventricular system, and then it's developing this non-protein bound iron after destruction with the hemoglobin, and then accumulation of the different blood projects causing this free radical mediated injury of mostly of the white matter, but also the whole brain structures. And the experimental data that done mostly on the animals showing that the early intervention have more benefit than the later intervention. So like previous speakers mentioned, there is an unsolved dilemma about how to manage the children with this post-hemorrhagic ventricular dilatation. So there's these two different main approaches. One is like using for the serial ultrasound when we measure the size of the ventricles, and if the ventricles starting progressing, we do different kind of interventions. And the second one is a decision based on the clinical symptoms that also quite widely used in the world. So when the fontanelles start bulging, when the head circumference increasing, when the child developing apneas or vomiting, it's based on the basically clinical status of the children. There are multiple of the ultrasound indexes that used to measure the progression of the ventricular dilatation. And here I want to show the three major probably that is very widely used in different centers. It's anterior horn width that you can see on the left part together with the ventricular index, and the thalamo-occipital distance that is also one of the cornerstone in the measurements of the ventricular system. So there are different interventions proposed how to treat this entity, ventricular dilatation in post-hemorrhagic region. First of all, is in quite widely uses a serious lumbar puncture that we can do for almost every newborn that was born with the IVH. It buys us time, we get CSF analysis, and also we can decompress the veins. So I start to mention some data that we have now from different studies. The Elvis study that I think superficially mentioned already by the previous speakers. So it shows that then 2-3 repeated lumbar punctures allow to run out from the shunts in almost 25% of the patient, and it's a significant number. So when we can arrest the progression of the dilatation with the only 2 or 3 puncture, it's a great benefit the children can have. And another few dilemmas with the lumbar punctures, like people who doing this in everyday manner, they see that sometimes we have this phenomena when after several lumbar punctures, there is a drying up of the patient. So we're getting less and less CSF, and it's quite difficult to control this ventricular dilatation doing only lumbar punctures. And another thing that I want to mention about the neurostatus that was controversial from the Cochrane review that you will see here, the title that showed that there is no evidence that serial TAPs reducing the need for VP shunt or mortality or severe disability in this cohort of patients. So it's not still clear, we still lacking the robust evidence that telling us what is the best strategy. Here, the next step in the invasivity of the procedure is temporizing measures that you can see here. There are three basically main interventions that we can use and we can propose for our patients. First is subgallial shunt that in the left part. In the middle, you can see ventricular reservoir. The common is OMAI or RICAM. And the last one is EVD that also is quite effective in controlling ventricular dilatation or hydrocephalus. Regarding the data that we have about this combination of different modalities that I mentioned already, there is some data that's showing that using the serious lumbar puncture together with reservoir decrease the probability that these patients will get the permanent shunt in future, but it's still very not robust. And also there is some data that shows external ventricular drain will improve the cognitive function of the patient that is getting this modality of treatment. Laser study is another cornerstone study about the management approach for this patient. So it's reviewed the ultrasound-based approach and together with a clinical-based approach and try to compare these two different approaches in infants with the intraventricular hemorrhage, and they showed that the ultrasound-based approach has a similar results at the outcome of 2 years, and it is similar to even the children that never got any CSF drainage, and it's quite impressive. But still, there is a lot of discussion and there is a lot of controversy about the studies that each study has advantages and disadvantages. And also the same study showed that the clinical-based approach increasing the risk of the worst outcome. Next study that I want to mention is the Elvis study that is, I think also was mentioned before. They split the whole group of patients depends on the threshold when they want to intervene. One big group was lower threshold and another one group was high threshold. I'm not stopping on the small details about how they choose this, what is the parameters that they use. Here's is only the review of the results of the study that they got. So here in presenting the results, what they showed. So they found that there is no significant difference between the lower threshold and high threshold in primary outcome. And the primary outcome consists the rate of death and the rate of the permanent shunt insertion. Other thing that they showed that the decrease of the brain injury and decrease of the ventricle volume in the low threshold group. So the group where was intervention started early compared to the second group when the intervention started later when the ventricles was quite big. And there was another study that analyzed an outcome 2 years after the initial study that showed that the probability of the so-called bad outcome, including death or severe disability or developing test score less than 17, is less in the low threshold group compared to the high threshold group. I'm sorry, this is repeating of the other slides here. So in this graph that is quite also, I can say this, it's quite controversial about the width of the anterior horn. So here's the Dr. El-Deep and the colleagues, they put together the measurements of the anterior horn width from different studies. The red line and the blue line representing low threshold and high threshold group from the Elvis study, and the yellow line on the right side of the picture is representing the clinical based approach from the laser group, from the laser study. So they showed that the anterior horn width was correlating with the outcome that include the cognitive, motor, and the language developing of these children. The next study that I want to mention, and that is including in this review paper, it's a drift study that was quite good discussed before. It's the 77 patients with the post-hemorrhagic ventricular dilatation and relatively big ventricles was split between two groups. One is a drift and another one is the standard treatment. And this slide presented the major outcome what this paper showed us. So this study, I have to mention that this study was preliminary stopped because of the high secondary bleed that occurred in the drift group, 35% compared to the standard 8% group. So it was preliminary stopped because of this frightening complication. On the other hand, the primary outcome of the severe cognitive impairment was significantly better in the drift group that you can see in that we saw in the 31% of only the patient, and compared to the almost 60% in the standard group. And the next study that based on the drift article that published results after 10 years of follow-up showed us that the drift group of patients was significantly associated with less severe disability compared to the standard group of patients. The next study that is also need to be discussed is the shunting outcome in post-hemorrhagic hydrocephalus that split the group of patients between the subgaleal shunt and the ventricular reservoir shunt insertion. So they show there is a big number of patients, 65% will get eventually permanent shunt. And another outcome that the study taught us is there is no difference in rate of infection, CSF leak, death, or permanent shunt insertion in both of these groups. So at this moment, we have a quite weak evidence regarding the management approach that can be recommended for the patient with this post-hemorrhagic ventricular dilatation, but the preclinical data and the growing amount of evidence showed us that the early intervention based on the ultrasound approach can cause better neural development outcome compared to the late intervention or the clinical-based approach. So here's the traffic light that showed the continuum, like we all know from the traffic gyms and the roads when we drive. So here you can see that by the paper of Brouwer very nicely showed this splitting the three risk groups, that green representing the low risk, yellow is moderate risk, and the red is high risk group. So this, we're analyzing the size of the ventricles, like you see here, with the ventricular indexes, and during the time, changes in these ventricular indexes helping us to assess the risk of progression. Based on this, we can see the management approach that was proposed by Dr. El-Deep in his review paper. So there's 3 zones that we can split the all patients. First one is a green zone that I underline here, the main management and the observation in the NICU when we do serious ultrasound and we not intervene in any manner. The second one is the moderate risk group. It's a yellow zone when we consider doing the several LPs. Usually 2-3 is enough. There are several papers that show that the multiple LPs didn't change any outcome compared to the low number of the LPs. And the red zone, or the high risk group, the patient from this group need serious lumbar punctures and then neurosurgical intervention. There is still lack of evidence which neurosurgical intervention is the best for the children. And like previous speakers mentioned, there's a lot of work that should be done in this field. And I hope with the trophy and with other papers, we'll get this answer soon. Thank you very much for your attention.
Thank you very much. Thank you very much, Dr. Kozyrov. That's a very clear presentation, excellent presentation on a complex subject, reflecting the excellent paper of Dr. El-Deep and colleagues. If I could please ask Dr. Jallow, first of all, to comment on Dr. Kozyrov's presentation and the algorithm or the 3 zones that Dr. El-Deep and colleagues have proposed. And also just to comment on one of few things that I have observed. You know, I in my 2 years in Birmingham Children's, I only had to put one external ventricular, one ventricular access device, and that we had problem with breakdown of skin, etc., and then ended up putting an EVD and then putting a shunt later on. And LPs, when we advise our referring hospitals to do LPs, they are really rewarding. And so, Dr. Jallow, on these 3 broad points, thank you.
Well, thanks, Nair. Thanks, Danielle. I think that was a wonderful review of the paper. I think, when I read the paper, basically it makes sense. I think it is what what the authors are stating, that was what we should do. But in the real world, that doesn't exist. I mean, I think what ends up being performed is really dependent upon the institution that you're working at. As Naren says, he says you did 1 or 2 procedures at your previous center. I look at it locally, what our recommendations are, and we, for us as a team of 3 or 4 pediatric neurosurgeons, we already have variations in what we recommend to the neonatologist. We also cover several neonatal intensive care units, and what we do at one, we don't do at the other, and we can't, because if we ask, oh, let's do a lumbar puncture there, it doesn't happen. So a lot of it really depends upon the center that you're working at, as well as your training or your preference in terms of what you're doing. With that said, I think it would be great to be able to standardize it, say the green, orange, red light in terms of the management.
Thanks. Thank you very much, Dr. Jallow. Mr. Edwards, Richard Edwards, what's your thoughts on, first of all, on Kozyrov's presentation and on the management algorithm and how you see it practical? Thanks.
Firstly, thank you for an excellent summary of that paper, which was also exceptional quality. My take-home message from reading the paper and from your presentation is that there does seem to be a trend that earlier intervention appears, if we had enough numbers and enough consistency, to give a better neurological outcome. And I think we're put off with the drift study because of the risk of bleeds, although actually, again, the bleeds were fairly small. We had to record any type of hemorrhage that occurred, and they clearly didn't have a long-term neurological impact on the outcome. So the question is, do we need to be a bit braver and intervene a bit earlier? I think that's controversial, but the science side of post-hemorrhagic hydrocephalus suggests this is a TGF-beta mediated inflammatory response, and that the earlier you can intervene and prevent that if possible, perhaps the better. And Linda may be better able to comment on that than myself. I think the traffic light system is helpful. I think the biggest problem we have is consistency of expertise across centres, and it might be better that these babies are moved around to sort of centres where you get a higher volume of treatment. And I think it's an area crying out for randomised controlled trials. And given the numbers involved, I think it would have to be an international multi-centre study. And Shlomo is the only person who's been able to pull that off with endoscopic treatments, and that was a battle. And so I'll be interested to hear what the other panelists think. But my gut feeling is that we need to intervene perhaps a little earlier, and to try and moderate the inflammatory response that goes with these bleeds. But I'll be interested to see what others think.
Thank you very much, Mr. Edwards. Professor Shlomi Constantini, the same things about Dr. Kozirov's presentation, the paper, and any questions that you have for Dr. Eldib, Dr. Mohammed Eldib, and to Professor Deveris. Thank you, sir.
Well, thank you, Daniel. There was a very excellent presentation and short to the point. I was really happy to see this paper, especially because it was a combination of Dr. Eldib and Professor De Vries and Professor Volpe, really the pillars of neonatal neurology, together with our colleagues, pediatric neurosurgeons, to try to put things in a more practical way. I think anybody who is reading the literature on this topic can get lost very, very easily in the details. There's so many details. Some of them are confounding, some of them are confusing, some of them are misleading. And you need to put in a little bit of common sense within that frame of decision-making. Look, the real problem is how to differentiate between the yellow or orange and the red. Because LPs are LPs, and okay, you do an LPs, but once you start to do a skin incision, put a RICAM or do a subgaleal or put a drain inside, or of course, if you do the drift or the lavage, that's a different type of story. So what brings a baby from orange or yellow to red? And this paper tried to put it in a perspective that seems, for me, really as part of my, my old biases. And here is my biases. If somebody calls me for a consultation on a 1,200 gram baby who has growing ventricles after post-hemorrhagic IVH, and his fontanelle is down, and his head circumference is not crossing the percentiles, I would personally not agree to put anything into those growing ventricles. And I feel because of this tendency that Richard has been talking about, say, but look, the ventricles have grown 2 standard deviations or whatever. Say, I'm sorry, the fontanelle is down, there's no pressure, I would not drain it. Okay, of course, the counter argument is that it is the blood that makes the inflammatory reaction and we need to wash the bloods out. But for me, anytime you enter the skin into the brain, there is damage, potential damage, and complications. And anybody old enough in the profession knows that complications occur, especially with shunts. I was amazed, by the way, to see in the Lavage study that the rate of shunt revisions was significantly higher at the group that were treated early. Of course it was higher because the ventricles were small, the catheter of the shunt was not sitting in place, and there were blockage on those groups. So I like this colors. I like the definitions they gave in the review. And I think I would be very interested to see if on an international survey, people agree with the criteria they put in. I agree with them. They seem logical to me. And I'm especially happy that our fellow neurologists who are pushing me all the time to be more and more active agreed to those criteria.
Thank you. Thank you very much, Professor Shlomi Constantini. Professor Dear Pujari, you have a large practice, and I think we spoke earlier, and I think you are, if my memory is correct, that you prefer the ventricular subgaleal shunts. In terms of, the problem is that with all whether it's ventricular subgaleal or reservoir, once you have put it, then you have to send the patient somewhere else, whether they look after the patient the way you will look after the patient. As I said, even with just one, maybe that was just an exception, one ventricular access device in neurosurgical department, I had problem. So what's your thoughts on how, on the traffic system? Do you think this is a idealistic, or this is a practical, or this is something we should aspire to? Thank you. Professor Dear Pujari, yeah.
Just one moment. Sorry, I was muted. Currently, what we are doing is when the neurologists are either tired or don't want to do lumbar punctures, we would usually put in a reservoir. And if the child, the head circumference is increasing and the child needs repeated taps, say anything more than twice a week, we would go for a subgaleal shunt. This is what we have currently practiced for some time. Now, recently, when we take the child for, that's what I was saying, that in the last 2 or 3 cases, I think 2 cases, before we do the subgaleal shunt, we do a ventricular lavage. This is something which we have started only earlier this year. I do not really know, as Shlomi says, and I think there has been a very good review of the literature. We do not clearly know what is going to work. But one of the reasons why we were not sure what we should be doing was basically the post-operative care, where we have a lot of children, and we find it difficult to keep the children in special units where they could be cared for, and therefore setting up a EVD is virtually not possible. My question actually to what Shlomi was just talking about, putting a needle, we always know that however safe it might appear and minimalistic it might appear, it can also be damaging. Do you feel the same for repeated lumbar punctures, Shlomi? And does that also alter the situation, you think? Or is that equally damaging, you think?
No, I'm not afraid of repeated LP. The problem is that the LPs dry up, because each time you go in on this tiny space, there's a little bit of bleed in the epidural space, and it is very seldom that you can do more than 3 or 4 or 5 LPs. So they dry up, the LPs. So this is a temporary measure, a very temporary measure. I'm not afraid of damaging the spinal cord or the cauda equina if it is done by a professional. I know Uli, by the way, I don't know if he's still with us. When I called him the other day, he said they don't do LPs. They don't believe it is useful.
Just while we are talking about LPs, I used to work in Newcastle with Professor Mendilo, and for BIHS, he used to put lumbo subcutaneous shunts, basically a plastic tube that goes from the theca into the skin, and then he anchors it. would instead of a ventricular access device, would a lumbar subcutaneous shunt, would that be feasible in these little ones, Mr. Richard Edwards?
I think it will be equivalent of the ventricular Gallial shunt. I think just with the lumbar theca, but you need to have a sort of a pocket to create. And you were asking about how it is taken care of afterwards. After the first week or so, the children are sent home, and they usually their pediatrician is taught how to do the taps if necessary, or the children come back.
Sure.
I think that they're so small, these babies now, and I think the less you do, the better. A lot of the time, I mean the drift catheters. The advantage of the drift catheters, we did put them in on the NICU unit, so we didn't have to transport the babies, and that in itself can be a risky thing to do, to bring them to the OR itself. It, carries some risk, and I think it's a really tricky problem, and I think. Ultimately, I think only more RCTs is going to solve it, to be honest.
Thanks. Questions to Dr. Eldiman, to Professor Dever is, I think from from the neurosurgical point of view, when we get calls from the neonatal side, they are keen for the patient to come to us and to have a procedure done. We are keen to, at least in my practice, we are keen to try to delay the any sort of shunt procedures until 35 weeks or at least 2 kilograms. From your perspective, what would you say to neurosurgeons, and also in what Mr. Edwards mentioned about tumor necrosis factor? Do you think there's a medical way of treating this in future? Any injections intrathecally? First of all, to Professor Eldib, and then to Professor Devaris. Thanks.
So I thank Daniel for this great presentation, and for the panel for the discussion. And definitely, I was honored and privileged to publish this paper with really leaders in the field, and I learned a lot from them. I think that like my thoughts are there is waiting longer. I think one of the tables I like in this review was the table 1, when we compared the outcome of different studies over the years. Although the inclusion criteria is different, we could clearly see that the least number or percentage of babies who need GP shunt was those who either early or late intervention in the Elvis trial. And also, these are the babies who had the best outcome reported in literature. So I think the goal of this paper to say that it's time to take this, move this further than just waiting for more studies to prove the same point, that waiting too long probably is not a helping outcome by any means. I agree with many of the speakers that the devil lies in the details, that even putting the reservoir, the question would be, do you have a place that you'll be able to tap this reservoir? Are they doing it the right way? Do you have the right team to do it? It's interesting that we know that studies did not show a difference between a reservoir and subgaleal shunt. But if you look at the Elvis trial, they exclusively used the reservoir, and they were actually tapping it repeatedly. So what I don't know if the subgaleal shunt would have left the same results, especially that in this study per se, this was not used. So I think there are still some details, but and the practical part of applying this thresholds are very important. Definitely, the hope is to move this forward. So the idea of starting to surveying large numbers internationally in the neurosurgery field. I'd be very happy to be part of this. We have the Newborn Brain Society, which was established a year ago and has a really large proportion of neurologists and neonatologists who work in neonatal neurocritical care, who would also be happy to participate in such effort. So I think I hope this is just one step forward so that we can be more consistent, because without consistency in management, it's very hard to understand the outcome of all these practices.
Thank you. Thank you very much for your thoughtful comments. Dr. Professor Diveres, just one more additional question to you as well. In the paper, in the review paper, there was mention of many different agents that are either iron chelating or antioxidants. What are the hopes of medical management for these patients as well, in addition to the other questions I mentioned? Thank you.
Are you asking me?
Yes, please. Thanks.
Oh, I'm sorry. Well, thank you again for a very nice discussion. Well, there have been attempts in Korea, for instance, where they are now injecting stem cells into the ventricles or into the brain parenchyma, which I think is interesting. They now just started their phase 2 trial following publishing 9 babies in their phase 1 trial. I know that there's a group in Germany that have been giving nasal stem cells, intranasal stem cells, or by giving the preterm babies the mother's milk every time they're being fed, in the attempt that they're giving some kind of stem cells this way to the baby. And they've shown that there was some reduction in the need for neurosurgical intervention. And I think they're going to do a study as well. But otherwise, I think we are not having made a lot of progress for other drugs to be given to these babies with PHVD. But I think this will change in the near future.
Thank you. And in terms of the number of patients, neonatal patients with hydrocephalus, I know that in Holland you have got many neurosurgical centers. Is that a dilution, or I know that there's a tendency in Netherlands for centralization as well. Does centralization would make any difference for neonatal care, or you don't? What's your thoughts on that, please?
Yes, in Holland we've got 10 NICUs, but there are only 7 that actually have a neurosurgeon, pediatric neurosurgeon on board. So in Utrecht we are getting children from 2 other centers as well. And we used to do about, well, between 10 and 20 babies a year. And I think the more experience, the outcome is also going to be improved than just doing a single or 2 cases a year. So I think centralization probably is helpful.
Thank you. Thank you very much, Professor Diveres. So I thank again Dr. Daniel Kozyrov for taking us through his excellent outline of the very important paper. I think the paper by Dr. Mohammed Al Dib will be read by, pretty much anyone who should be read by anyone who's managing neonatal post-hemorrhagic hydrocephalus to know what's the current state of art is. Thank you to both Dr. Kozyrov and to Dr. Eldib, Professor Diveres and her team. Thank you very much. So it brings us to the third and last item of our program today. It's a lecture from Professor Chandrasekhar Diyapujari. I had a patient 2 weeks ago with TB meningitis, a 6-year-old boy. His GCS was quite poor by the time I saw him, about 8 or 9. He had been started on anti-TB medication a couple of days ago and steroids. By the time I saw him, he was starting to get better. Ventricles were large, but I kept a very close eye on, and actually he has improved and didn't have to do any intervention, neurosurgical intervention. But I read the lovely, excellent chapter of Professor Diyapujari in the hydrocephalus textbook of hydrocephalus by Chinali and Sendros. So I want to get Professor Shlomi Constantini, who knows Professor Diapujari more than me, to introduce Professor Diapujari. Professor Constantini, thanks.
Well, that's easy. That's an easy job. Chandrasekhar is a mentor, a master surgeon who has pushed pediatric neurosurgery in India to levels which we are going to hear about more and more in the next decade. I'm not sure how many of you know that in India, there are 18 million children born every year. So there is a huge need for pediatric neurosurgery in India. So Professor Diapujari laid the basic foundations of pediatric neurosurgery, I think almost single-handedly, but there were others as well. Some of the most important pupils in India come from his school. He's an endoscopist, he's a skull-based surgeon, he's a gentleman, he's experienced, and he's my friend. So thank you very much.
Thanks, Shlomi. That's very kind. I think though the number of children being born is probably reducing, but it is still going to be fairly high compared to the Western world. And unfortunately, there are certain diseases which are more prevalent, and we probably have more experience with them. This is one of those diseases, unfortunate diseases about which Naren has asked me to talk, and I have gathered some literature and some personal cases to illustrate a few points. Should I start, Naren?
Please, Professor Diapujari, thank you.
Right. So tubercular disease is fairly common. We will just look at some of the figures through the world. It usually begins in lungs, as most of you know, and 1 or 2% of the infection reaches the CNS and progresses to tubercular meningitis. Even in UK, there are about 150 to 200 cases reported each year, and hydrocephalus is a more common complication, especially in children. And this usually happens 4 to 6 weeks into the disease if it is not properly controlled, and has a more severe manifestation in children than in adults. Though it is an ancient disease, has become treatable only in the last century. And though the ventricular estimation, taps, intrathecal therapy were all described earlier, it was only in 1951 when streptomycin became available, some kind of a treatment could be offered to these patients. The famous heart surgeon, famous for his heart transplant surgery, actually initially during his early days worked on tubercular meningitis, and he has noted that only about 23% patients out of the 259 children they treated in Cape Town at that time had internal hydrocephalus. However, as you will find from this early paper on CT study in tubercular meningitis by Tandon and co-workers from All India Institute, New Delhi, who got one of the first CT scans in India, it seems that almost 87% of children with tubercular meningitis developed hydrocephalus compared to about 12 to 13% of adults. And this was one of the initial presentations. To the extent that they have noted, he has written in this book on tuberculosis in 80s that we probably mistook the sequelae. This was initially mentioned by another medical historian, and we thought that hydrocephalus was the main component rather than the disease in the meninges. And some of the times, I think when neurosurgeons are treating the patient, we also sometimes probably forget the disease. So this was in connection with making us aware that we need to look at this. You find several papers coming from all over the world talking about the prevalence of tuberculosis. This is one such paper from Indonesia, where again this is a quite a common disease. And 2010 paper by JMK Murthy, one of our senior neurophysicians, has written and taken a lot of data from world literature to show that almost 2 206 patients per 100,000 population is seen in India. And the incidence rates are age specific, and most of them occur in children. And I think the estimated mortality due to tubercular meningitis in India is 1.5 per 100,000 patients. And HIV certainly increased the prevalence of tubercular meningitis for quite some time. Today, we know that it is higher prevalence in HIV positive patients, but on the whole, the disease has become milder, and currently we do not know if the incidence has decreased or not. Basically, the disease can spread either hematogenous from the pulmonary infection. It can go through the blood and establish itself in meninges, or sometimes there is a subcortical focus, what is called a rich focus, which can burst and develop into meningitis or ventriculitis very, very rarely. And a very extremely rare mechanism which has been mentioned is a rupture of tuberculoma in a vessels in subarachnoid space, or contiguous spread of infection from the adjacent bone. There are less than 100 cases reported of tubercular osteomyelitis primary developing into secondary meningitis. The peculiar thing, unlike the usual meningitis, the exudates is not mainly on the surface of the brain. It is usually at the basal surface, and it also causes ependymitis and choroid plexitis earlier in the disease. So the pathology of hydrocephalus in tubercular meningitis is because of the thick basal exudates blocking the arachnoid cisterns, that is the decreased absorption, which develops into a communicating hydrocephalus. Second is that the exudate becomes like an obstructive collar in the ambient cistern, and you may have an occasional tuberculoma in the ventricular passage leading to obstructive hydrocephalus. Again, as I said, the thick exudate collar or secondary aqueduct stenosis can again cause obstructive hydrocephalus. And in some patients, the choroid plexitis can cause increased CSF production, and you can get a communicating hydrocephalus. We just talked about this, that you can get both varieties of hydrocephalus, and we just talked about their mechanism as well. Another mechanism which is being mentioned for all kinds of post-infective hydrocephalus is that they probably affect the ciliated ependymal cells so badly that when the cells are shed off and when they regenerate, they probably have metaplasia and do not develop the cilia again. And therefore, even if there is some kind of a repair, once it is a post-infective meningitis, you tend to have ependyma which is not so good in terms of CSF absorption, and you can still develop a communicating hydrocephalus. And therefore, this may be another mechanism in patients. Even when the disease is controlled early, you can still have progressive hydrocephalus in those patients. Most of us know about the disease much better after the CT became available, and CT features showed the tuberculomas, basal exudates, and hydrocephalus very, very well, as you can see in some of these pictures. CT with contrast became the mainstay of the disease when we were residents, and we would usually talk about mild hydrocephalus when the temporal horns were dilated, which was treated with mainly lumbar punctures. We'll come to the treatment a little later. Moderate and severe variety. However, there was a great difficulty in sometimes finding out that without much of hydrocephalus, if the patient is sick, we used to believe that the patient has encephalitis, but you did not have a clear signs on the CT scan, and the same for perforator kind of infarcts. MRI not only showed the basal exudates better and gave us earlier information about the increased ventricular size, it also told us much better about the subependymal seepage, presence of infarcts and tuberculomas, even if they were small. But more importantly, we noted the ischemia, which occurred mainly in the basal ganglia and the brainstem. And sometimes you could see very, very extensive basal exudates with tuberculomas, and these patients were more prone to have brainstem ischemia. One other thing, fortunately rare, is the formation of tubercular abscess. a typical abscess, unlike the pyogenic abscess you would find in the subarachnoid spaces, you would find that they have a very, very regular border. And unlike the tuberculomas, which become hypo-intense on T2 weighted images, these remain hyper-intense, suggesting that this has turned into abscess. The main difference is the anti-tubercular treatment does not clearly work on these patients because penetration is very poor. So though tuberculomas can be treated with medication alone, tubercular abscesses need tapping, and that is one definite area from where you will always get AB positive bacilli. Cine MRI is important if you want to know, if you are not sure about the nature of the hydrocephalus, if you are unsure about the nature of the hydrocephalus, and it can show you if there is a communication in the ventricle and the subarachnoid space. Earlier, and especially the Cape Town group has actually made some of the treatment decisions based on this, that they would inject air and do a CT ventriculogram or just a plain X-ray, and showed the difference between communicating hydrocephalus and a non-communicating hydrocephalus. The clinical presentation ranges from altered sensorium, raised ICV features. The CSF picture shows usually the lymphocyte predominant pleocytosis. There are decreased glucose levels in the early phase of the disease, and the diagnostic yield for CSF is usually very, very low. It is clearly seen only in abscess kind of situation. Otherwise, you hardly ever get organisms in these patients. And today we are mostly dependent on antigen-based tests. ADA levels are usually high. Is the disease same in the young children and adults? Obviously, you can see that there is a late appearance following spread of primary complex. So you may have late in the course of the general tuberculosis, but patients are acutely ill. Hydrocephalus is much more frequent, and in children at least there has not been much increase. It is mainly an adult disease where HIV has made a great impact. Most of the patients, most of the people to study prognosis as well as to decide on treatment protocols have staged this disease. The Medical Research Council first staged it into 3 categories depending on the level of consciousness and localizing signs. The Valor group classification in 1991 had become very popular, and then they upgraded it to use the GCS as a criteria, and this is the most commonly used classification, grade 1, where the patient is very much like the subarachnoid hemorrhage grading. Pharmacotherapy of tuberculosis, the first line of treatment, you obviously start these patients on as soon as you get your diagnosis, you start them on anti-tubercular treatment. They are also started on steroids, and the drugs are given for a minimum of 9 to 12 months, though in common variety of disease, nowadays the consensus is that a 6 months treatment is good enough for extra CNS tuberculosis. CNS tuberculosis usually gets still 9 months, except for pot spine. Second line of anti-tuberculosis drugs are administered in case of drug-resistant tuberculosis, and these are the first line, second line drugs, and newer agents have been used in drug-resistant cases. A recent study has shown that the main 4-drug treatment which starts initially is rifampicin, isoniazid, pyrazinamide, and ethambutol, and almost all patients with CNS affection are given prednisolone, and clinical follow-up with improvement of symptom, weight gain, and monitoring for any adverse reaction is done once a month. Steroids are started because of one couple of studies which have shown that the incidence of first of all, there is a clinical improvement is much rapid, and second is the hydrocephalus formation probably could be reduced. This is again not proved statistically, but there is a feeling amongst the neurologists that the ischemic side effects also reduce with the use of steroids, and therefore most of the patient gets steroids for 4 to 6 weeks. You will use diuretics and decongestive therapy if necessary in seriously ill patients. And we all know that thick basal exudate and patient who is worse than grade 3 are definitely poor prognostic signs. In our own institution, my mentor, Professor Bhagwati, had started this trial with hyaluronidase intrathecally for tubercular meningitis to see if the incidence of hydrocephalus comes down, but we did not find too much benefit from it. At another center in Bangalore, they have shown a marginal benefit by injection of hyaluronidase in the subarachnoid space. So shunt is the most commonly performed procedure whenever you require surgery for this hydrocephalus, and endoscopy third ventriculostomy is getting popularity, and we will discuss their role. Ventricular atrial shunts were in fact initially described and were found to be useful. And as I was just telling you that my mentor was probably, this was the first paper coming out of Mumbai for tubercular meningitis associated hydrocephalus with a significant benefit with a VA shunt. So this was the first paper. Another 8 or 10 years, we had a similar paper from Durban and then from Cape Town. And then, of course, because the shunt were not perfect devices, there was a question of should you be using them in all patients? And the Vellore paper, which showed the grading of the patients, also showed that in poor grade, we should probably be doing EVD to see the response before we consider a patient for shunt, to see the prognosis, and then endoscopic third ventriculostomy was evaluated. So today, I think the standard indication for surgery are grade 1 and grade 2 communicating hydrocephalus after adequate medical therapy. If there is a rapid deterioration in patient's consciousness, if there is a radiological evidence of progressive enlargement of ventricles, if the CSF manometry suggests progressive increase in intracranial pressure, and if there is an obstructive pattern of hydrocephalus, then you do not really look at other parameters. Ventricular trap was routinely done initially in all patients before shunt was considered, but it has been found that ventricular CSF is not badly affected in tubercular meningitis, even if you have a great raised protein and lymphocytic response in the lumbar CSF. The ventricular CSF is fortunately not so badly affected, and in most patients you would be able to go ahead with a shunt procedure. Very rarely protein content may become a problem, but tubercular ventriculitis is not so common. External ventricular drain can be used as temporizing tool in grade 4 and 5 patients to see if they are improving, and this is indirectly will tell you that if hydrocephalus is the main cause or the ischemia of the brainstem basal ganglia is the main cause for patient's deterioration. And then I think this paper has studied the role of shunt quite well and has mainly talked about the fact that it is the grade 2 and grade 3 patients which benefit the most. In grade 1 patients, you could still probably treat them with lumbar punctures and steroids before you decide that patient requires surgery. But grade 2 and grade 3 patients are immensely benefited by surgery. This is a patient. You can see that she presented actually with tuberculomas to begin with, and then she developed hydrocephalus, and then this is after putting the shunt, and she showed not only considerable improvement because of a raised intracranial pressure, but even the tuberculomas have responded better. So another theory which is quite prevalent is that the drainage of CSF probably improves the permeability for the drugs, and the tubercular infection also is better controlled in patients who have had a reduction in their ICP by a shunt. Another factor which has emerged in this paper, Dr. Rajkumar from Lucknow has shown that compared to other indications for shunt, in tubercular meningitis hydrocephalus, the shunt failure rate is much higher. They have shown it more than 37%. And similar papers have come out of All India Institute and SGPGI, as well as from Dr. Sandeep Chatterjee, my colleague in Calcutta. that they all feel that the use of shunt is probably much more prone to blockage than in for other indications. Because this was found, there was a possibility of third ventriculostomy was considered. This is another recent paper in 2016. I think this is from another institute in North India, which has actually shown that there is no statistically significant increase in the complication rate in TBM patients. So there is some disparity, but many people feel that in tubercular meningitis, it is a higher percentage of shunts which get blocked. So this is a patient with resolving tuberculomas with increasing basal exudates, and then you will find that even if the shunts do not get regularly blocked, some other complications can develop. Like this patient developed a blown up fourth ventricle and then required a fourth ventricular shunt. So you may have trapped ventricular system in various areas in such patients. This is another patient who had a temporal horn trapped and required shunting of that as well. So endoscopic interventions were therefore started, and I think one of the first papers which showed reasonably good results in these patients in about 60% of patients was from Cape Town. And I think this is a slide I have borrowed from Fegan, and it is so good that I have still kept it in my results. So usually you like to see when you do a third ventriculostomy something like this. But in tubercular meningitis hydrocephalus, what you get is that you can make that opening, but then you find that there are several membranes and several kind of adhesions in the prepontine space, which make it very clear to you that the basal subarachnoid space will not, the CSF will not circulate properly. The floor of the third ventricle is frequently thick, and therefore there may be even failure to perform ETV. And after performing the ETV, you may still find scarred prepontine space. You can also see these subependymal nodules while doing the endoscopy, which are seen when there is an associated ependymitis as well. And in chronic TBM, it is not such a major issue because even though the exudates are there, they get organized and you find some evidence of good subarachnoid space, and it may be possible that it will work properly like it worked in this particular patient. And as I was telling you earlier, the use of air injection to decide if it is obstructive hydrocephalus or communicating hydrocephalus before performing a third ventriculostomy is a technique which has been mentioned by the Cape Town group. This is another patient. This patient actually came primarily with a shunt, and 7 years later, patient came back with blockage of shunt. At that time, we decided that as the fourth ventricle was not enlarged, we went ahead and did a third ventriculostomy. So basically, secondary third ventriculostomy has become quite popular and it works quite well, especially in a burnt out disease like you find in this patient. Previously shunted patient came with a shunt blockage. We went ahead and did a third ventriculostomy, and we have published our 36 cases. Most of them are post-meningitic patients where the shunts got blocked and the ETV worked quite well with more than 72% success rate. So today, I think in grade 1, grade 2, grade 3 patients, depending on the duration of tubercular meningitis, if it is less than 4 weeks and the patient has progressive hydrocephalus, you'll go for a VP shunt. If it is more than 4 weeks and patient is being treated properly and responding to treatment, you can consider an ETV, but usually ETV is reserved for patients who develop delayed hydrocephalus after the disease has come under some kind of a control. I'll show you a typical example. This is a young girl who came with tubercular meningitis, did not have hydrocephalus at that time, then developed hydrocephalus, had a shunt done, and then actually developed a slit ventricle syndrome. And the shunt was removed about a year later. But then she had reactivation of the disease about 6 years later, again developed hydrocephalus, and this time she could be treated with a third ventriculostomy. Though the floor of the third ventricle is a little opaque, it could be opened and subarachnoid space is quite patent, and this worked quite well, and this girl had just finished her graduation now. And we usually check this at 3 months with a cinecystosonography, and this has been fairly reliable marker, though there is one patient which has failed in a delayed manner. So there are now several papers which talk about ETV in post-tubercular meningitis patients. It has come from 3 or 4 groups in India and the Cape Town group, and most of them have shown anywhere between 30 to 60% success rate in these kind of patients. Other advantages of endoscopy can be, this is one patient who was shunted because of tubercular meningitis hydrocephalus, and 2 years later patient came with shunt malfunction. One ventricle is completely drained out while the other ventricle is enlarged, and in such patient just a simple septostomy worked quite well, and the patient could be benefited without putting in an extra shunt or revising the shunt. We have written about endoscopy in post-infective hydrocephalus, a review we have presented in this special volume of Child's Nervous System a couple of years ago. You will find that in grade 4 and grade 5 patients, in spite of good treatment of hydrocephalus, in spite of the ventricular size coming down substantially, you will find some patients do not respond. And this is possibly either due to encephalitis or more likely due to ischemia. And most of these patients would show you some infarcts in the basal ganglia or the brainstem. So there are obviously several gaps which in the diagnosis as well as management, because the disease is more common in children, but we do not have biomarkers and certainly not widely available to identify children prone to poor outcomes. We also have a problem that can we really do a prophylaxis for the contacts of the patient. So basically, I think we have still got some gaps, though the government has actually made medicines quite well affordable, and most of the tuberculosis patients can be treated at a very, very low cost today. There is still a reluctance, and I think patient compliance is still a big problem. About development in a delayed manner on these patients who have been shunted or who have had endoscopic third ventriculostomy, a recent paper from Cape Town has shown that many of these patients, in spite of the fact that their hydrocephalus is treated in good time, still may have evidence of cerebral ischemia as well as some deficits due to encephalitis. So basically, I think early treatment along with anticoags, to use steroids, and appropriately, most importantly, timely done CSF diversion are probably important to get good results. Thank you very much for this opportunity to share this.
Thank you very much, Professor D. Pujari. That's a comprehensive lecture from your extensive experience, and also taking us through the literature and the current state of management of TB hydrocephalus, which is can be quite challenging. There's a question from Dr. Koventev, Sergey Koventev. Thank you for this very interesting presentation. What is your opinion on the use of aspirin or other anticoagulants in TB meningitis to prevent stroke? It's maybe slightly different, but do you use any antiplatelets?
No, it is not being used, and I haven't actually read any literature on this. I think the mechanism is arthritis. It is not the endothelial what should I say, endothelial dysfunction which causes the strokes. It is the arthritis which causes end arthritis kind of thing, which happens to the perforators, which results in these infarcts. And therefore steroids have been greatly sort of beneficial and have been supported, rather than using any kind of antiplatelet drugs or anticoagulants.
Thanks, thank you. Mr. Edwards, I know West Country is a lovely part of the world. I'm looking forward to joining you. In do you have you had come across any TB hydrocephalus in your practice?
I think in 15 years we've had 2 TB hydrocephalus, so pretty different practice to Chandrasekhar in India. You know, I think it's a very interesting insight, the role of delayed endoscopy, waiting for all the inflammation to settle down and using it there. It seems to be something we should give thought for, perhaps with other, you know, any infective hydro, and that was a very valuable insight, Chandrasekhar. Thank you very much for that.
Thank you, Mr. Edward. Professor Shlomi Constantini, do you see a TB hydrocephalus in your part of the world?
Not even one.
No.
I'm sorry.
That's very good. Excellent. I presume St. Petersburg in Florida is devoid of TB hydrocephalus, Dr. Jallo?
I think we've seen one in the last 5 years.
Yeah, I think probably Birmingham has the highest rate of TB hydrocephalus. Certainly, Mr. Solanki has a good collection, at least 10 where he had shunted with good outcomes. Professor Dear Pujari, I have a few questions for you, if that's okay. You know, when I used to do adult neurosurgery, when we had patients with the hydrocephalus secondary to meningitis, you know, when I used to, the ventricles are very large, I put the EVD and the pressures are actually very low. In the TB ventriculomegalies, do you get high pressures, or once again the brain compliance is changed?
This is really a difficult question to answer, because in questionable cases, I have occasionally done ICP monitoring in these patients, especially in adult patients who come with this kind of a disease, and we are not sure when the ventriculomegaly is not too high. And I think the trial of EVD has been suggested mainly for this reason by the Vellore group, and we have followed that at the same time rather than depending on the pressure. Whenever the patient's clinical condition is poor and there is ventriculomegaly, which is probably not as marked, and the pressures are not as high, you would still give them a chance of what kind of recovery they make in 24 to 48 hours, but not beyond 48 hours. Our threshold of taking out ventricular EVDs are very small. So
Thank you.
Pressures don't become too high, that is for sure. But I think the most important thing is, as you said, probably the compliance is important. And if the patient benefits with drainage, I think the shunting works quite well.
Thanks, thank you. When I was in Royal London, that was adult practice, I had a young lady about 19 years old. She had been shunted for post-tubercular tubercular hydrocephalus in another place, and then she developed aqueduct stenosis, and then had basically trapped fourth ventricle and also blocked VP shunt that she had originally. After, you know, once again with big series of one, I then became a bit anxious about over draining these patients with infective hydrocephalus, and I was a bit reluctant to put a EVD on even this kid. Thankfully, he moved in the right way without me doing anything. But what's the dangers of over drainage? How easy it is to over drain, and does over drainage actually the cause of the aqueduct stenosis from inflamed ependyma sticking together?
So I think this is probably one thing which happens, and this may be one reason why the secondary third ventriculostomies are successful. I think many of these patients who have had shunts for some time, and when they start malfunctioning, it is also because of probably aqueduct stenosis, which occurs with the rapid drainage of the CSF. And these patients respond well to third ventriculostomy. For trapped fourth ventricle, if it is in a post-infectious hydrocephalus, I have tried to see if I can pass a Fogarty through the aqueduct in addition to doing a third ventriculostomy. But I have never done any rigid kind of maneuver to do open up the aqueduct in such patients. The fourth ventricle, trapped fourth ventricle needs to be treated by a separate shunt in this particular kind of hydrocephalus.
Thank you. And the last question from me, if anyone else has questions, please put your hands up or put it on the chat box for me. In terms of doing LP, with this tubercular meningitis, the adhesions being in the basal cisterns, how, in terms of the safety of doing LPs, how do you have an algorithm for going? You mentioned about injecting air. How can avoid any inadvertent coning?
No, I think injecting air was probably an important part of earlier work before the days of, I think it was before the days of MRI, and they probably still use it as they started doing it, and they find it fairly reliable. But what we do is MRI will give you a clear idea of either the obstructive or the communicating nature of the hydrocephalus. And I think if you have no signs of obstructive hydrocephalus, it is fairly safe to do lumbar puncture. And there are people who also talked about doing a lumboperitoneal shunt earlier, but that is not being practiced anymore for another reason, that arachnoiditis, if at all it happens, spinal arachnoiditis can be a very, very serious issue. So most people would depend on either or would do a lumbar puncture without any issue. Associated arachnoiditis can be the only reason why your lumbar puncture may sometimes not give you adequate information. But otherwise, I think lumbar puncture is a fairly safe thing to do.
Thank you very much, Professor Dia Pujari. Mr. Edwards, do you have any questions for Professor Dia Pujari?
No, I think it's a masterclass. I was listening with great interest. But Naren, I'd like to just thank you as well for such a fantastic journal club. On behalf of all of the panelists, we've really enjoyed it, I think, and it's been really great. So thank you very much for taking the time to organise it.
Thank you very much. I appreciate the senior panelists and all the participants taking their time on a Sunday. I think it gives us an opportunity for the young residents to present and also get input from the masters. And I really appreciate all your time and your expertise, and also to all the participants and also our speakers, Professor Dia Pujari, thank you, sir, and to Dr. Neera Shimoni, and for Dr. Daniel Kozurov for the excellent presentations, and all the authors, Dr. Uli Tomale and Professor El Dib, and for Dr. Diveris to join. I think it was in some ways, it was quite a nice event. Dr. Jallo, can I give you the last words and before we close? Thank you.
Naren, once again, thank you for a wonderful journal club. I mean, I think I can't imagine the amount of organization it takes to bring people together to have both the papers presented as well as the authors attend the journal club. I do want to thank you, all the reviewers, as well as the authors of the papers for coming together on a Sunday to present two papers, as well as to learn about TB meningitis. I mean, I think for me, I've spent the last several hours just amazed by the knowledge I've gotten from this session. So thank you, and thank everyone for participating.
Thank you very much, Dr. Jallo. Thank you very much, everyone. The session is recorded and it's on the YouTube channel. I will put links on the various social media and the emails, so that you know where the link is, so you can always go and revisit the lectures and digest it and think through and send questions to Professor Dia Pujari or Dr. Shimoni or Dr. Kozirov. Thank you very much, everyone. See you soon. Bye for now.
Naresh. Nice session, and see you soon.
Thank you very much, Professor Dia Pujari. Thanks a lot. See you soon, Richard. Thanks a lot. Thanks, Neil. Thanks a lot.
Good job, Naren. Mr. Naren, well done.
Who's that?
It's Togi.
Hi, Togi. Welcome, Togi. Hope you found it useful, Togi.
Yeah, well
Great to have you here. Great to have you here. Hello, Angela. How are you?
yeah, okay.
Yeah, okay, good. Excellent.
I'm on.
Angela, you still there? Are you on call?
Yeah.
Good, good. Excellent. Angela, you there? I'll write to you over the email. Take care all. Have a nice evening.